Alrighty, everybody. Welcome to the lecture. We will be doing chapter 14, BLS resuscitation today. So as part of most EMT courses, you will be expected to have a CPR card or a BLS CPR certification at some point throughout the course. This is kind of a different perspective on that. Remember, end of the day, we're still going to be going off of AHA rule until you have some sort of certification that's going to be pushing you towards more of a high-performance team dynamic. Okay, so moving through BLS resuscitation. So principles of BLS, basic life support, introduced in 1960. Since then, we've had specific techniques that have been reviewed and revised fairly regularly. We want to make sure that we're always providing the best care possible, being patient advocates. So most recent review is 2020, conducted by the International Liaison Committee on Resuscitation, or ILCOR. Moving on. Now, remember with BLS, comparatively to if you advance your scope into the advanced realm or paramedic realm, there will be more things that will be happening at that point in time on cardiac arrest type calls. But when we talk BLS, BLS is non-invasive. Okay, so non-invasive emergency life-saving care used to treat medical conditions that include airway obstruction, respiratory arrest, and cardiac arrest. Now, respiratory arrest and cardiac arrest, those two things tend to be tied together, right? If the heart fails, the lungs fail. If the lungs fail, the heart fail. Now, realistically, when it comes to your patients, it could be kind of either or. I will say statistically, more frequently than not, children tend to go into respiratory arrest and then cardiac will follow. Inversely, adults will be in cardiac arrest with respiratory arrest following that. So the big focus when we talk about BLS is always going to be ABCs. If you've done any assessment chapters or if you've looked into assessments at all, this is going to look very familiar. Now, when we're talking the principles of BLS, we're talking airway obstruction, okay, breathing. We got to make sure if they're in respiratory arrest, we have a BVM to take care of that. And then circulation, right? So cardiac arrest, we're going to be doing chest compressions to improve circulation. If there's severe bleeding, we got to stop that, right? That way we're not just pumping blood out of the body every time we do compressions. Now, ideally, only seconds should pass between the time you recognize a patient needs BLS and the start of treatment. Time is of the essence. That is one of the biggest things. We need to be on the chest circulating blood. If we are not circulating blood very efficiently, we are doing our patient no favors. So permanent brain damage is possible if the brain goes without oxygen for roughly 4 to 6 minutes. And I'll show you a better table on that throughout the lecture. Here we are. So time is critical, like I was saying. So 0 to 1 minute of no oxygen, we start to have some cardiac irritability. This is from the perspective of respiratory functions diminishing first. Okay, so that 0 to 4 minutes, no oxygen, brain damage not likely. Still not trending well. Obviously, we want to be perfusing the brain, but at this point, they are still very viable. 4 to 6 minutes, there is a possibility that brain damage will start to develop secondary to hypoxia. 6 to 10 minutes, no oxygen, brain damage is very likely. Now, if we go more than 10 minutes without oxygen, that hypoxia will start to create irreversible brain damage. Now, here's kind of the kicker and why layperson CPR is so important. The golden standard of response time across our country is 10 minutes, right? So if someone goes down, we get dispatched out. We're supposed to be there within 10 minutes of that dispatch, or in a perfect world, we are there within 10 minutes. This is why layperson CPR is so important, because if we can get somebody on the chest prior to EMS arrival, we tend to have better outcomes because there's less hypoxia happening, right? Now, even if it's hands-only CPR, you're doing what we call passively ventilating. If you think about it, it kind of makes sense. If we push down on the chest, we're forcing an exhale. As we allow full recoil, we're allowing the chest to expand and pull a little bit of air. Now, obviously, it's not going to be as successful or as good, for lack of a better term, as using a BVM, right? But it is something, and it still keeps that oxygenated blood circulating throughout the body until responders can get there. Now, CPR, cardiopulmonary resuscitation, kind of dealing with our ABCs, right? Reestablishes circulation and artificial ventilation in a patient who is not breathing and has no pulse. Chest compressions supplement the pulse. BVM will supplement the breathing. So our steps, first things first, restore circulation. Always, always, always get on that chest as soon as you know there's no pulse, no breathing. From there, open the airway and then restore breathing with rescue breaths. If you're going to be a lay person, you will probably be using a pocket mask if you have one. I would say if you're going to do mouth to mouth, maybe, typically in the field, that's not something we would do so much. Obviously, we have our BVMs. But if you're going to do something like mouth to mouth, I would, for myself, would save that for my family. But realistically, if I had to, I would. Now, quick image, right? Doing chest compressions, we got the BVM hooked up to high flow oxygen there. So BLS does differ from ALS, like I was saying kind of earlier, right? So ALS on the medic side more so includes things like cardiac monitoring. We do not use an AED as paramedics. Paramedics are the AED. We will put them on a cardiac monitor, which will then give us the rhythm interpretation, or the medic will then go through and use rhythm interpretation and decide shock, no shock, what's our next course of action. Included in that list is things like IVs, IOs, intravenous or intraosseous access, which will then allow us to push fluids and get meds going. And then on top of it, at the ALS level, things like advanced airway adjuncts. So LMAs, iGels, King tubes, even endotracheal intubation, all in the paramedic scope. If you're going to be an advanced EMT, things like LMAs and iGels may be in your scope depending on your state protocol. Now, when we talk about CPR, there is some components we need to talk about, right? This is a chain of events that will need to kind of build on each other, right? So the 6 links of the chain of survival. So first things first, someone goes down, no pulse, not breathing. Does somebody recognize that this is even happening, right? Once we have recognition, let's start calling 911. From there, hopefully the layperson has some sort of CPR training, CPR background, so they can start getting on the chest, okay? Start doing immediate high quality CPR. From there, rapid defib, right? Now, the layperson who is trained in CPR will know how to use an AED, allegedly, or on paper, they'll know how to use an AED. These stressful moments tend to bring people kind of a make it or break it moment for some people, okay? But in a perfect world, layperson sees someone go down, starts CPR, gets an AED there, puts the pads on, starts running the code as the layperson. Once the first responders show up, they will take over, right? So basic and advanced EMS. And then from there, once we have, if we get pulses back, or ROSC, return of spontaneous circulation, that's where we will have ALS post-arrest care. So at the medic scope, there are different medications we can give, things like epinephrine, norepinephrine in a cardiac arrest setting to, a ROSC setting to hopefully increase either heart activity or to bring those blood pressures up. And then if all goes well, we have a recovery, hopefully with minimal brain damage due to hypoxia. Okay, so whenever we talk BLS, first things first, before even CPR, make sure the scene is safe, right? You guys will hear it 101 times when you're in an EMT course. BSI scene safe. Now, things to consider. We can say BSI scene safe all we want, but we have to be realistic and rational. What are the hazards around us? Pay attention. And we'll talk about it, right? If they're in water, is there snow? Are they on something that could be conductive, right? We got to make sure we're paying attention to our surroundings, not just for our patient safety, but for our own. Now, complete primary assessment as soon as possible. ABCs, that look, listen, feel, hopefully is simultaneous. Okay, and then at that point in time, determine if they're unresponsive or not. Now this, in a realistic, ideal world, should take no longer than 10 seconds, okay? Now one thing I also want to draw your attention to, One thing I want to draw your attention to is when we do this look, listen, feel, okay? Notice when I'm checking pulses, I'm keeping my face down by the mouth so I can feel the breath, watching the chest, feeling for a pulse. Notice I am on the same side I am on. I'm not reaching. This looks bad, right? It looks like I'm choking my patient. And if we're talking about lay people watching this situation, because there will be people watching these situations, it can make it a little bit dicey from a layperson perspective, right? So make sure we're not doing anything that might make us just look worse than what's actually going on, because this is already a stressful situation. So kind of talked about it already, right? So recognition, activation of our emergency response system. From there, immediate high quality CPR. Hopefully we have an AED on scene. We can start getting that over there. We can do a rapid defibrillation. make sure that defib, or hopefully that defib is going to get them back into a perfusing rhythm, okay? And then after that, first responders, basic and advanced emergency services show up, ALS and post-care arrest, and then our recovery if patient makes it out of there. Now, assessing the need for BLS. Basic principles of BLS are the same for infants, children, and adults. There are some caveats in that when it comes down to the ratios of compressions to breath. That might change a little bit, but in the end, it's all the same 3 principles, A, B, C, right? We got to make sure we're keeping an open airway, breathing for them, and getting circulation. Now, as I kind of mentioned earlier, this is going to bullet point it. Although cardiac arrest in adults usually occurs before respiratory arrest, the reverse is true in infants and children. Kids are breathers, okay? In fact, fun fact, more often than not for a bradycardic child, one of the go-to options for treatment is oxygen, okay? Their breathing tends to give out before their heart. Now, the reason this is the case is because kids are growing constantly, meaning their cellular demand is really, really high, meaning they need more oxygen more frequently than adults do, which is why if you have a child at home and you notice they're breathing fast all the time. Same with their heart rate, it's fast all the time because they're trying to circulate as much perfusing oxygen and sugar as they possibly can. And then here's a little look, or not look and feel, hey, you okay? Checking responsiveness, right? So check from the shoulders. You may even try a pain response just to see if you get anything there. Work your way down the AVPU list there. Now AEDs, pretty vital link in the chain of survival, right? Talking about it. If their heart is in one of 2 rhythms, 3 realistically, but one of 2 rhythms that are shockable, ventricular fibrillation or VFib, or ventricular tachycardia, known as VTAC. Those are going to be 2 shockable rhythms that if the AED senses them, can deliver a defibrillation dose to hopefully basically unplug the computer, plug it back in. We're not trying to stop the heart, but we are trying to momentarily get a pause so that the heart can regenerate its normal heart rhythm. Now, there are going to be some rhythms that are not shockable, so don't be surprised if in real life, if someone's down for a while, the AED tells you no shock advised. They could be in asystole, which for all you Grey's Anatomy fans is your flat line, right? The boop. There's another one, PEA, pulseless electrical activity, which on the paramedic monitor, it'll look like they have a heartbeat. What we're concerned about is that, yes, it looks like they have a heartbeat on the monitor, but when we check a pulse, there's no palpable pulse. Okay, so pulseless electrical activity kind of defines itself. Now, if you witness a cardiac arrest, start CPR, get that AED on as soon as available, okay, as soon as you have it there. Now for kids, apply after first 5 cycles of CPR. We want to make sure that we are oxygenating them as best we possibly can before we shock that heart, hopefully into a normal rhythm, because we want to make sure that as soon as that heart reestablishes a normal cardiac rhythm, that we are going to immediately begin reperfusing everything that was not being perfused prior. For kids, we got to use pediatric pads. There also is dose attenuators. So basically kids don't get shocked at the same intensity that adults do. Okay, so they're small people, they need smaller doses, so that attenuator helps to just adjust that. Now, if we have no pediatric pads, we have no attenuator, we're still going to use the AED, we're just going to be using the adult pads. Now, the pediatric pads are designed to go fairly similar to the adult pads on the kid's body. If we do not have those pediatric pads, we will do an anterior-posterior with the adults, meaning adult pad will be on the front of the chest, and then one pad will be on the back, hopefully lined up symmetrically through the torso. Now, there are going to be some specific situations that we have to keep in mind. First one being if they have a pacemaker or an implanted defibrillator. Okay, we do not want to put that pad over that device. That electricity is going to fry that pacemaker. Okay, now what we're going to do is put that pad at least an inch away from where that pacer is. Okay, that way, or even the defibrillator. That way we can make sure that we're not hitting that piece of equipment, rather we are still transferring that electrical shock through the patient, through the heart. The next one, wet patients. Now, AHA is kind of defining this a little differently nowadays, but if somebody is wet, say it's a drowning, we pull them out of the pool, unconscious, unresponsive, pulseless, apneic, we got to start CPR. We want to dry them off as best we possibly can. Now, AHA is saying that if they're in a puddle, you can still use the AED, and that's fine, follow AHA. In my mind, it does not take more than a few seconds to get them to a drier spot. Yes, that puddle may develop if they're wearing wet clothes, but at least we're setting ourselves up for success. And the last one is transdermal medication patches. We don't want to put the pads over those patches. And realistically, depending on what the patch is, that could be the reason the patient's in cardiac arrest. For example, say they have a fentanyl pad on them. Okay, we want to make sure that we are double checking that one, is this patch causing the problem? Two, if there's a patch where our pads should be, pull them off, wipe them down. We do not know how that medication will react when combined with electrical forces. Okay, so make sure you're doing yourself some due diligence, looking out for your patient. We don't want to cause the situation, cause the situation to get worse. As far as positioning goes, for CPR to be effective, patient must be supine on a firm, flat surface. So no CPR on beds, no CPR on couches. In an ideal world, we are down on the floor. We don't live in an ideal world, however. So if you need to make adjustments, you can put things like a backboard underneath the patient, keep them on a rigid surface, depending on the space you have allotted. If you can get them to the floor, get them to the floor. Okay, make sure you have enough space for at least 2 rescuers to perform CPR. Okay, and then like I said, we can always log roll them on their side. That way we're protecting any potential spinal involvement. Put the long backboard underneath them, roll them back there, and then we can get on the chest, start doing CPR. I kind of talked about it earlier, but checking for breathing and pulse, right? We want to visualize the chest for signs of breathing and palpate a carotid pulse. Want to emphasize again, palpate a carotid pulse. We do not want to use the radial pulse. You could also use the femoral, carotid or femoral. Carotid is going to be the easier accessible one. But the reason we don't use a radial pulse is that different pulse points register at different blood pressures. Okay, so for example, you can feel a carotid pulse if we have a systolic of around 60 systolic. We can find a femoral at around 70 systolic. We lose our radial pulse when we go south of 90 systolic. So do not use the radial pulse as our pulse check. That way we're not missing things, right? And the last thing we want to do is start chest compressions on somebody who has a blood pressure of, 70 because we checked a radial pulse. Because if they wake up, they're going to be pretty pissed when their chest hurts because they weren't dead, okay? From there, we have no pulse, they're apneic. We want to start getting on the chest. So chest compressions, apply rhythmic pressure, relaxation of lower half of sternum. We need to make sure we are paying attention to our landmarks. At the base of the sternum, we have a little tiny segment of bone connected with cartilage called the xiphoid process. The xiphoid process hangs down just below the sternum. So if our hand placement is too low, we break that. We could send that into the lungs, send that into the heart. So make sure we are not over the xiphoid, just above. Okay, and then we're going to start compressions. By compressing, we are forcing that heart. We're squeezing the heart, simulating a heartbeat of sorts to push blood forward. Okay, and then avoid leaning on the chest in between compressions. So I'll come back to that. When it comes to overall chest compressions, we are shooting for anywhere from 100 to 120 beats per minute. Okay, so pick your favorite song that has that there. Lots of good ones out there. Okay, and we want to avoid leaning. Reason being is we want to allow for full chest recoil. If we don't let that chest fully recoil, we're not letting the heart fully expand. If the heart does not fully expand, we're not filling it with blood as effectively as we could. So therefore, our next compressions are going to be limited by the amount of blood that's actually being pushed around the body. Okay, so allow the chest completely recoil between compressions. Once again, proper hand placement is crucial. And then injuries can be minimized by proper technique and hand placement. Now, here's the kicker, and I'm sure some of you have heard this before. When we do CPR, we're breaking ribs. Technically, we're not. We're disconnecting the sternum from the cartilage that's connecting the ribs to the sternum, but you will be feeling a popping. We need to separate that sternum. It's kind of an unfortunate cruelty we have to do. You will know you're establishing good compressions when you have popped and broken all of that cartilage off the sternum. You can also tell if somebody's doing ineffective compressions if you're the second person up and you continue to break things, right? We want to make sure that we are doing a good job. Now, the goal is not to punch a hole through someone's chest. The goal is not to break every bone in their chest either. But we got to be efficient enough to separate what we need to separate. Yeah, so lungs, heart, right? They lie underneath that sternum, which would be just over the front here, which if we think about that xiphoid process, it hangs right about here. So if we break that, we run the risk of shoving that places we don't want it to be. Yep, so we're gonna compress down and allow for full recoil. That way we are fully pushing blood out and fully reestablishing that refilling phase, okay? Now, opening the airway, depending on the situation at hand, is gonna dictate what method we elect to use. If we're worried about something like trauma, maybe there's some sort of head, neck, back involvement, we want to use the jaw thrust. That way we are not going to be kind of fiddling with that neck and maybe running the risk of causing further damage. To do the jaw thrust, you will feel behind the mandible where it's still going if we're standing up and down. And we want to put our 2 fingers and push that jaw forward. We are trying to give them a massive underbite, as you can see in this image. Now for me, because I have big enough hands, I like to also put my thumbs on the chin. So thrusting forward, thumbs on chin, pushing down, up and down, opening that airway. If we are not worried about head, neck, or spine injury, say it's just we'll call it an older person who years of bad choices have put them in cardiac arrest, not even bad choices, just years of choices have put them in cardiac arrest, we can use the head tilt chin lift. So as you see in the image here, pushing down on the forehead, lifting up on the chin, causing that neck to open. We're keeping a nice open airway when we do that. Okay, but make sure you're using the correct method for whatever situation we have at hand. Okay. Now, if the patient is adequately breathing and there are no signs of injury to the head, spine, hips, or pelvis, place them in the recovery position. That is going to be on the left lateral side, okay, which I believe there's an image of it here. Yes, left lateral side. This does a few favors for us. First and foremost, it maintains a clear airway. If you've ever had or been around somebody who's been intoxicated on alcohol and you know they're probably going to vomit, you lay them on their side. If this person is going to puke, they're going to puke, but they're not going to be choking on it, okay? So maintains clear airway, allows vomit to drain from the mouth. And then we can always roll the patient as a unit, right? Especially if we're worried about head, neck, spine involvement. So here's that left lateral. You can also see that the right leg is out in front to kind of create a counterbalance. Now, another reason we specifically choose the left side, not the right side, is because of the anatomy we have. Okay, if I go back a few slides here, you can see what I mean. So, on the right side of the patient's heart, we have 2 sets of what we call the great vessels, our superior and inferior vena cava and the aorta, okay? Well, if we're on our right side, we're allowing the mass of the body to potentially compress those 2 vessels, which if you think about it, if you know anything about AMP, that's the vessels that aorta sends blood to the body, vena cava returns blood to the heart to reoxygenate, then send to the body. We are essentially kinking the tubing or kinking the hoses. That's going to further kind of damage our ability to resuscitate this person. Because now, if they have low blood pressure, there could be a situation where now they have less blood returning to the brain and heart, less blood being sent forward, so it kind of creates a potentiating problem. Now, the combination of lack of oxygen and too much CO2 in the blood is lethal. We don't want to be hypercarbic or hypercapnic, meaning we have too much CO2, right? Obviously, hypoxia is a problem. If we think about perfusion, oxygen, sugar, waste removal going on, we need to have those processes happening. So this is kind of sensical, right? It also does things to our blood chemistry, such as shifting our pH, but we won't talk about that too much right now. Now, if the patient is not breathing, ventilations can be given by 1 or 2 providers, okay? Using a barrier device, which is what I see. So single provider, we will use the CE method. Okay, I've also heard the OK method, depending on the size of your hands. It makes a difference. If you have small hands, the OK method around the stem of the mask on the BVM will get a better, more even seal. These extra fingers can grab and pull the face towards the mask. That same principle kind of applies as the CE, but once again, if you have bigger hands. If you have big enough hands, you can do that CE method. Just make sure that you're placing a consistent pressure around that mouth so we don't lose oxygen as we ventilate, we break that seal. Always use a barrier device, you just never know. This is a big deal during COVID. We needed to make sure that at any given point, we need to have some sort of separation between provider and patient just because we never know who's sick and who's not. So here's an example that CE, you can tell just based on the finger placement. Out of the two letters, this is kind of a trick question I love to throw at my students. Which one's more important, the C or the E? The answer is the C. We want to make sure that seal is consistent and even. Because the last thing we want is people trying to overemphasize the E, and by doing so, they break that seal, so now we're leaking air out of one side or the other. For stomas, if a patient has a stoma, right? So a stoma is a hole in the neck, typically things like throat cancer, as an example. It's like when people who smoke for years and years and years, they can end up having this hole in their throat where they breathe through. If they have a stoma, we can use a BVM. We can put the mask directly over that hole, or if we have a pocket mask, depending on the situation, put it over the stoma. Now, one thing to consider also with ventilation, anytime we are artificially ventilating somebody, we run the risk of gastric distension, meaning we are filling their stomach full of air. You are essentially creating the world's worst water balloon when you do that, because when it pops, it doesn't so much pop as vomit will then exit through the mouth, making our job harder. So this is why it's important. Make sure we have that airway open, jaw thrust or head tilt, chin lift, okay? When we deliver a breath, we don't want to be crushing and squeezing that bag as hard as we can every time. A lot of BVMs nowadays will hold up to about 1,200 cc's of air. The average tidal volume or amount of air per breath in humans is about 500. Okay, so we can very, very easily over-oxygenate them, okay, or squeeze too much air, and we run the risk of popping lungs and things like that. So don't over-squeeze. Next thing, when we deliver a breath, you should be delivering a slow, gentle breath, usually over about a second or so, okay? And then always, always, always have suction available in case they vomit. It happens, okay? And it's not even because of gastric distension every time. There are sometimes when you show up and there's already vomit in there. Having suction available will go a long, long way. So here's an example of that stoma, like I was talking about. You see the hole in the neck there, using a BVM directly over the top. I've typically seen people actually use pediatric masks over that stoma, and it works a lot better. It's just less tissue to deal with, smaller mask. Takes up less space on that neck. And obviously our neck does not have as big a surface area as our face. Now let's say you're a single rescuer for adults. You show up, you're the only one there. We have a very set ratio of compressions to ventilations. And that ratio for single rescuer adult is 30 compressions to 2 breaths. So you'll do your 30 compressions, getting that adequate depth and rate. Depth is about 1/3 the chest, okay? And then our rate 100 to 120, allowing for full recoil. After we get our 30, give 2 breaths. Now, pro tip, well, I guess I can save it for when we go 2-person, but regardless, get used to counting your compressions out loud. 1, it helps you stay locked in, but 2, when other people show up, they're gonna know exactly where you're at, okay? Because the last thing you wanna do is start bagging or start doing compressions and bagging, and people are like, where are you at? And you're like, I'm not sure. Make sure you're counting out loud. Now, there's different techniques to this. For me, myself, when I used to do compressions, or when I would do compressions, I would go to about 10, and then I'd say 15, 16, 17, 18, 19, 20, and then from 20, count 21, 22, 23, so on and so forth, till we get to 30, okay? But keeping everybody in the loop. Now, let's say you are a 2 rescuer, which if you are going to be on an ambulance as a first responder, you will usually at minimum have 2 people. Depending on your system, some systems will carry 3. But it's always preferred to have 2. 1, we can swap compressors because chest compressions get very, very tiring. AHA recommends that we swap about every 2 minutes or so. because it will tucker you out. But less tiring also facilitates more effective chest compressions. If you're not tired, you do better compressions. If you're stuck on the chest for 4, 6, 8 minutes, you will start to do poorer and poorer chest compressions as you get tired. That happens. So switching rescuers during CPR is critical for maintaining high quality compressions with, once again, switching positions around every 2 minutes. Depending on your system, that might change a little bit. Now there are different devices that we will use to help with our outcomes for CPR. First is active compression, decompression CPR. Always involves compressing the chest, then actively pulling it up to its neutral position. Hands are going to be our gold standard, and I'm sure people already know where I'm going with this when it comes to compression devices, but your hands are the gold standard. Now there's also impedance threshold devices, okay? So this limits the air entering lungs during the recoil phase between chest compressions. We don't want to overfill the lungs because then we run the risk of popping lungs when we do chest compressions. Okay, so that's where that slow controlled breath over a second. Okay, so here's an active compression, decompression CPR device. Once again, it works great. It's kind of a plunger, but if we don't have it, not a big deal. We can make sure that we have the high quality hand CPR, okay? Golden standard. There's that impedance threshold device. Now there are mechanical piston devices as well, so it allows rescuer to configure the depth and rate of the compression. One of the most common ones used around is the Lucas. The Lucas is a heck of a device. Essentially, it punches a hole square through the center of someone's chest. It's a big old plunger. You put a back plate down. It's kind of a U-shaped arm that fits around the patient. Plunger goes down on chest. You hit go, and it starts to go. It's kind of a violent procedure, so this is also a situation from a responder perspective. If you can get family away from this, they don't necessarily need to see this. Now there are also low distributing band CPR, vest CPR, so a circumferential chest compression device composed of constricting bands and a backboard, and then which there's an image of that on our next one. But last but not least, once again, manual chest compressions are the standard. That is the standard of care. At minimum, you need to know how to do CPR with no devices, because here's the kicker: not every patient you have will fit into these devices. One of the last cardiac arrest calls that I ran, our patient was very, very distended to the point where we were almost doing chest compressions at a 45-degree angle just because of his anatomy. So our Lucas at the time did not fit, one, because of his width and size, but two, just because of that way that stomach was distended up. And here's that load distributing band, right? So it clicks onto the backboard, and then you can start using that for compressions. Okay, so things do kind of shift. So adults, single rescuer, double rescuer, 30 and 2, until eventually you get an advanced airway, and things will look different depending on your system, okay? But for children and kids, it does change. So cardiac arrest in infants and children, once again, usually follows respiratory arrest, with airway and breathing being the big focus. Keep that in mind. With pediatric BLS, airway and breathing is the bigger focus than the chest compressions, okay? So some possible causes of respiratory problems: injury, infections, foreign body, i.e. they choked on something, submersion, getting underwater, things like drownings, electrocution, poisonings or overdose, or SIDS, sudden infant death syndrome. All of those are potential respiratory problems we'll see. Now, first and foremost, nothing really changes when we show up. Determine unresponsiveness. Gently tap on the shoulder, speak loudly. With kids, because they have a smaller anatomy, I, from my own practice, use the feet. I would hit their feet, because if you slap a kid's foot, they're going to react, okay? But you can still shake them a little bit. Baby, you okay? Check for breathing and pulse. Make sure it's happening simultaneously, no longer than 10 seconds. Now, here's another thing. With adults, we're always looking for that carotid artery, or maybe the femoral artery, right? Depending on what you have access to. With kids, especially infants, they tend to have that really big head, small neck, right? Really top-heavy little buggers. So it's harder to feel that anatomy, especially if they're like I'll call it a fluffier kid, right? They've got that neck fat. It's harder to feel through. So we're going to use the brachial pulse in children, brachial being in the bicep, right? Easy way to remember, made a brachiosaurus, little dinosaur. My brachial pulse is attached to my brachiosaurus, okay? Now, if there's a foreign body obstruction, right, it's a very common thing for kids to choke, especially, if you've gone through lifespan development chapters, you'll see there are times in their lives where they are just putting things in their mouth. That's how they learn the world, okay? So, not uncommon for them to choke. Place some unresponsive breathing child in the recovery position, right, as long as they're breathing. Okay, but if they're unresponsive and pulseless, we're going to start a CPR. Now, the techniques for opening the airway are modified for pediatric patients. Yes. Kids' anatomy is different. They tend to have a more pronounced occipital bone, bigger occiput. So if we lay them supine, they're realistically going to have their head kind of pushed forward just because of their own anatomy. So to supplement that, we're going to take a towel or a sheet or whatever you got, roll it up for at least an inch, and we're going to pad under their shoulders. By padding under their shoulders, if their head is tucked down, we pad the shoulders, we kind of force that airway to open up and keep it more in line. Okay, so place a wedge under the upper chest and shoulders when supine. Now, rescue breathing, right? We're going to provide rescue breaths as needed. Now, if the child is not breathing but has a pulse, they're apneic but have a pulse, we deliver one breath every 2 to 3 seconds. Okay? If they're not breathing and have no pulse, it's going to be 2 breaths every 30 compressions, right? Now, this is going to be our single rescuer. We'll talk about double rescuer here in a moment, but not breathing, no pulse, 2 breaths every 30 compressions. Not much changes there. If we're going to talk 2 rescuers, especially for kids, we actually shift our ratio to 15 compressions, 2 breaths. That way we are prioritizing breaths, right? We're giving more breaths more frequently as opposed to the 30 and 2. For interrupting CPR, so the way I've always, or a lot of diagrams have shown us, is that when you do chest compressions, you bring circulation up, right? So every time we do a compression, we're bringing the circulation level up. Well, the second we get our hands off the chest, that circulation starts to slowly dwindle, right? And that's every time, even delivering breaths. Now, the further we let that go, it's going to take us a few compressions, and usually studies are showing about 9 to 10 to get us back to that circulation point. So when we stop, or if we pause compressions, we have to be really on the ball. We want to make sure it's quick. Okay, CPR is crucial life-saving procedure. So if no ALS available at scene, provide transport per local protocols. Okay, this is also something that if you're en route, you can always call ALS, see if they can rendezvous en route to the hospital. If, say ALS is 15 minutes out, but you're 10 minutes to a hospital, more often than not, it makes way more sense just to go to the hospital, get to definitive care. So, like I was saying before, try not to interrupt CPR for more than a few seconds. Okay, so that chest compression fraction, the amount of time we spend on the chest during a cardiac arrest. Total percentage of time during a resuscitation attempt in which chest compressions are being performed should be at least 60%. Now, depending on where you're located, depending on your protocols, a lot of systems will shoot for 80%. 80% of that cardiac arrest episode should be spent doing chest compressions. Now, there are going to be times when we don't start CPR. We show up unresponsive, not breathing, apneic, pulseless, right? There are times when we just will not start, and there's specific reasons for that. First and foremost, if the scene is not safe, if we ourselves are not safe to run the cardiac arrest here in the space, wherever you're at, you're only creating a potential problem that you're going to need to call more rescuers in for, and now you are part of that response, okay? So keep that in mind. That's why scene safety is always so pushed. Now, another time we won't start is if there's obvious signs of death. This person is already deceased. They're at a point where we cannot help them anymore. First one being rigor mortis. The body gets stiff. Most seasoned providers will actually walk up to most cardiac arrest patients and they will start by jiggling their jaw. If their jaw wiggles, that person is still viable. We can still do chest compressions. If it is rigid and stiff, that person is past what we can do. The next one is dependent lividity, otherwise known as liver mortis, okay? Which I wonder if there's the image. Yeah, this is gonna be that dependent lividity, okay? So this is bruising. So this person died laying supine. So when they were, their body was breaking down, all of that blood was seeping out of the organs and is now settling at the bottom, at the base. Okay, that's gonna take a few hours to kick in. This person has been dead for a while. If they're at putrefaction or decomposition of the body, they are essentially just decomposing, right? This is something which the smell will hit you long before you actually see this body. One of the deadest bodies I ever saw, I smelled him from outside the house before we even got close to the house, to the front door, okay? Pretty obvious sometimes. But at that point, there's not much we can do either, right? They are so far gone that their body is literally decomposing. And then if there's evidence of a non-survivable injury, so patient got cut in half, their head got cut off, chest is broken in half, right, or cut in half, there's nothing we can do for these people. It's an unfortunate thing, but end of the day, we're not going to do much. I would say with things, especially with rigor, we actually run the risk of doing more harm than good if we start CPR on these people, because if there are bystanders or family, realistically, all we're doing is providing hope for a situation that there is none. Okay, so keep that in mind. If you see these signs, we do not start CPR. And it's a hard thing to do. It really is. When there's people who are screaming, yelling to help somebody, and you know that there's nothing we can do for them, you have to get good at these hard conversations, okay? And it can have any varying sorts of responses from family and patients, bystanders rather, but keep that in mind, right? We don't want to give false hope for a moment that there is none. Now, another time we will not start CPR is if the patient and physician have previously agreed on a DNR order, a do not resuscitate. Okay, now when in doubt, start CPR. So there's a couple of kind of intricacies to this. I've talked to different providers and they have different practices. So say we show up, grandpa's down on the floor, grandma says, hey, he's got a DNR, do not resuscitate order. Grandpa is cardiac arrest. Well, when we ask her, can we see that form? She says, I cannot find it. We have a couple of choices to make. For me and my care, and this is the one that I would venture to say is probably the most legally safe, is start chest compressions. Start doing a 30 and 2, run a basic cardiac arrest, okay? Because we cannot just leave somebody there. Legally, in the eyes of the law, we need to act. If we do not have a visible patient DNR form in front of us, signed by doctors, dated appropriately, signed by patient as well, we have to start. I've also heard of some providers who will say, okay, I'll give you 5 minutes. If you can find it in the next 5 minutes, I will not start chest compressions. If you don't, I have to, okay? Now this is a field of gray. It's a tough distinction to make. I would venture to say you are always legally defendable by just starting the CPR. Now there will be times where you do that and things can go south. For example, my wife actually ran a call for a gentleman who recently had an open heart surgery, got called for a cardiac arrest. When they showed up, the patient was apneic and pulseless. My wife elected to start chest compressions because the wife could not find his DNR order. Well, they start running the cardiac arrest, and there's more complications with that opening of the wound and such, but I won't get into it. They run the cardiac arrest. When she finally walks out, the wife finally walks out and says, hey, here is this DNR order. They had pulses. Whoops. But end of the day, she still did the legally defendable thing. And I believe that gentleman ended up expiring in the hospital as well. Anyway, but keep that in mind, right? It can get a little dicey with DNR. So make sure you know your local protocol. Make sure you are following up with people who are in your department who are experts on the DNR. Okay, because there can be some gray areas that can get us into a lot of trouble. Now, when do we stop CPR? Okay, we know when to start CPR, pulseless, apneic, no DNR, none of the definitive signs of death. But when do we stop? So, once you begin CPR, continue until you hit the STOP acronym. Patient starts breathing, has a pulse. We've gotten ROSC, okay? The T, patient is transferred to another provider of equal or higher care. Remember, that's going to be our legal handoff. We cannot hand off to someone at a lower scope than ours. It has to be equal or higher. The O, you're out of strength. You've been doing chest compressions for 20 minutes. You're running out of strength. You're tired. There's no response coming. You know that we are kind of running out of time. It's not a fortunate one. It's not one that anyone wants to do, but it is a harsh reality. If you've ever done chest compressions, you know it gets tiring and eventually you will run out of strength. And then the last one, physician directs to discontinue. So at our agency where I was working, we would run every cardiac arrest for at least 20 to 25 minutes, okay? Regardless of rhythm, 20 to 25 minutes. If we hit that 25-minute point and we are still in a cardiac arrest rhythm, there's nothing going well, we will contact a physician via medical control, and we'll ask them, or we'll kind of give them the layout. Hey, this is what I've done compressions for X amount of time. We've got X amount of, or X interventions done, intubation, IV, medication, so on and so forth. How would you like us to proceed? And more often than not, they say, go ahead and do another round of CPR, try another epi. If you do not get pulses back, you can call this time of death. Now that is going to be at the paramedic scope more frequently than not, but it is the last in our STOP acronym as to when we will not continue CPR. Now, part of BLS is also going to be choking, okay? So foreign airway obstruction in adults. So for airway obstruction, it can be caused by a few different things. First big one, relaxation of throat muscles. Fun fact, the biggest naturally occurring airway obstruction that we have as humans is our own tongue. The unresponsive person, their throat will relax, tongue will fall backwards, therefore blocking airway. Okay, this is why we use the OPAs, fun fact, so we can slip that in there, hold the tongue out of the way. If they vomited or regurgitated stomach contents and they aspirate or breathe that in, or even it's blocking the airway, right? Can't get air in, that's gonna be a foreign body. If there's blood in there, if there's damaged tissue, things like dentures, okay? I'll come back to that. And then foreign bodies, so they're choking on steak is the common example, but just choking on whatever they are eating. But dentures, if they have loose fitting dentures, if you know they have dentures, like say you're at a healthcare facility, a home health facility even, and they say, hey, they have dentures and they're in cardiac arrest, if you can wiggle them, try to get them out. Now, if they don't just come out really easily, you know, we're gonna leave them in, but dentures can create an airway obstruction as well. Now, in adults, when it comes to choking, it's usually during a meal, right? People don't chew their food, they're talking, they're breathing in while they're talking and eating, and then there you go, choking. In kids, it's usually during a meal or at play. Now, we all know children, right, that sometimes that's a bit of both, right? Go and take 4 bites of your food, then you can go back to play. Come back, 4 bites of your food, go back and play. This is one of those things where it tends to tie together, okay? Now, it's not only that kids tend to put things in their mouth, right? I've had a few calls for choking kids on coins as being the big one, or hard candy even. Okay, so keep that in mind. Kids can choke for any number of reasons. Now, a patient with mild airway obstruction is able to exchange air, but with signs of respiratory distress. So let's say someone's choking, but they're still breathing and moving air. We're not gonna fiddle with them too much. We want them to continue breathing. We're gonna try and have them cough that out, okay? Now, if we have a sudden severe obstruction, it's usually easy to recognize in responsive patients, the international sign of choking, right? People grabbing at their neck. Now, if in an unresponsive patient, suspect obstruction if maneuvers to open the airway and ventilate are ineffective. So we have an adult potential choking. We go to use our BVM and there's massive resistance. We are just not pushing air forward. Assume it is a choking at that point, okay? Now, what are we gonna do? If it's a conscious adult and they're choking, we're going to start with the Heimlich maneuver or the abdominal thrusts, okay? Now, recommended in responsive adults and children older than 1. We're gonna put our thumb in our hand, cup it into the belly button, and instead of going in, we're gonna go in and up. We're trying to compress those lungs and force that obstruction out, okay? And here's an example. Now, let's say, well, we'll come to it. If we have someone who maybe is pregnant, right? Obviously, we don't want to do abdominal thrusts on a pregnant woman, or even someone who's morbidly obese. They're just so large, we physically cannot get our arms around them. We can use chest thrusts instead. And it's the same principle, squeezing at the chest, trying to force air out of the lungs. Now, once again, this is in responsive folks who are doing the Heimlich or abdominal thrusts, okay? So there's your example of the chest thrust there. Now, let's say they go unresponsive. We're doing the Heimlich, someone's choking, we're doing the abdominal, trying to get them to get that out, and they go unresponsive. First things first, check for pulse, check for breathing, right? We wanna make sure we're not missing anything. If a pulse is present, breathing is absent, we're gonna attempt ventilation. If we still cannot pass air through, right? If 2 attempts to produce visible chest rise, we're gonna actually start doing CPR. Perform 30 compressions, open the airway, look in the mouth. By pushing on the chest, we are still forcing air out of the lungs, hopefully popping whatever's they're choking on loose, okay? And then make sure you're looking into the mouth. Now, never, ever, ever, ever do we blind finger sweep. They choked on something. We're not gonna reach our fingers in and try to blindly scoop whatever that is out. Reason being is that we could accidentally end up pushing that deeper and deeper and deeper and making our own problem worse. Now, if we take a look, we do our chest compressions, we do our abdominal thrusts, whatever, we see the object, you can flick that out of their mouth, right? Reach in and grab it. But also remember, people bite down, okay? So be kind of careful when you're putting your fingers in people's mouths. If you see it, flick it out of there. If you don't see it, you're gonna continue with your chest compressions. So, foreign body airway obstruction in infants and children, pretty common problem as we've already talked about. Now, if there are signs and symptoms of airway obstruction, do not waste time trying to dislodge the foreign body, okay? We're going to go, if they're responsive, we're gonna go straight into that abdominal thrust. And remember, we're gonna have to get down at their level, depending on the size of the child. Okay, so you're gonna kneel down behind them. If you have something conveniently close to you, like a chair, you can stand them on the chair. But regardless, we want them planted on something, feet planted on something. Now, on an unresponsive child older than 1 year, manage in the same manner as an adult. So the responsive, we're gonna do the abdominal thrusts until they go unresponsive or we clear the obstructor. If they go unresponsive, we're gonna lay them down. We're gonna start our chest compressions. Let's start trying to force that out and keep blood circulating, okay? So this image does a good job of making sure that you can see right down at the child's level so that we can make sure we're getting effective abdominal thrusts. Now, infants, do not use abdominal thrusts. They changed the game. They're a little smaller, right? So we're gonna do 5 back slaps and 5 chest thrusts. So you're going to, if we have the baby, hand face down. In my hand, we're gonna use gravity. Usually use your leg rested if you're sitting. And we're gonna give 5 forceful blows to the back between the scapula. Once we do that, we're going to flip them over. 5 chest compressions, usually using the 2-finger method. 5 chest compressions. And once again, use gravity. Keep their head angled down. Once we get those 5 chest compressions done, we are going to take a look. Do we see the obstructor? If so, pull it out. If not, flip them back over, 5 back blows, flip them over, 5 chest compressions, take a look, and so on and so forth. That cycle will repeat until you either see the object and get it out, or we are now running a cardiac arrest call. Okay, so image here, you can see the 5 back blows in between the scapula, and then you can see the 5 chest thrusts, and a very unhappy child in this image. Now, in unresponsive infants, begin CPR starting with chest compressions, right? So we're gonna do our 30 and 2 as a single rescuer. If we're gonna be dual rescuer, 15 and 2. Now, do not check for a pulse before starting compressions if we know they're unresponsive, okay? Open the airway, look in the mouth, remove the object if we see it. If not, resume chest compressions, okay? Now, there are going to be some special circumstances we have to consider. First one, opioid overdoses, things like fentanyl, heroin, oxycodone, hydrocodone, morphine, all of the opioids or opiates, okay? Standard resuscitation measures, we're going to do the same thing as needed. Only difference being we can use naloxone or Narcan, typically IN at the EMT basic level, okay? Now, things to consider with Narcan. We show up, someone is apneic, not breathing, but they still have a pulse. First things first. Well, let me rephrase. We know that they're gonna need Narcan. We look at their pupils. They have those pinpoint, teeny, tiny little pupils. That's one of the go-to signs that we have some sort of opiate on board. Okay, we know that Narcan is what we need. While we are drawing that Narcan up, that patient is still not breathing. So we need to make sure that we are still ventilating this person, okay? Now let's say, if it's a normal cardiac arrest and we suspect opioids, we will continue CPR. Just at that point, we may give Narcan at some point, okay? Now, if it's a pregnant woman in cardiac arrest, our priority is to provide high quality CPR and relieve pressure off the aorta and vena cava. When we lay a pregnant woman supine, they run the risk of going through what we call supine hypotensive syndrome. That weight of the baby is now pressing into their abdomen and compressing and kinking that aorta and vena cava. Because remember, the aorta and inferior vena cava run from our heart to about our pelvis. Okay, so that's prime real estate for a pregnant woman's baby to kind of smash into that space. Okay, so what we will do is somebody will manually displace that abdomen, or the pregnant abdomen to the left, okay, left lateral. Now, if anyone's ever spent time around a pregnant woman, that's not an easy thing to do. It's easier said than done. You're just looking for some sort of relief, pull it over. Another thing you can do, take towels, blankets, roll them up and pad under the right side, kind of forcing the patient to go from here to a little bit of an angle. This is going to allow us to, one, still do chest compressions, but two, we are bettering our circulation because we are no longer kinking those great vessels. Okay, so these are hard calls. These are the calls that I like to say bring human moments. And don't shy away from these human moments, because you're going to need to get good at having these conversations if you want to have longevity in your career. But family members may experience a psychological crisis that turns into a medical crisis. Someone on scene is very upset based on the person's death around them. Justified, right? There are teams that we can call, psychiatric crisis lines, that they can show up and they can help in these circumstances. Okay? If it gets dicey to the point where you may be in danger, it is okay to get law enforcement involved as well. Okay? You got to defend yourselves, protect yourselves. Now, I'm not saying throw hands at everybody, right? But if it starts getting to the point where you fear for your own danger, get law enforcement there. Now, family members and loved ones will remember this event in detail for the rest of their lives. I'll come back to that because I have some very particular points. And then keep the family informed throughout the resuscitation process. Keep them in the loop as best you can, okay? Now, going back to, they'll remember the details. The optics are everything in this, okay? I've been on calls where cardiac arrest, we call somebody in the field. You know, we kind of developed a gallows sense of humor doing this job because you kind of have to. The last thing you want them to do, though, or you want to do, is have somebody laugh on scene. And not even if it's related to the patient, but it's making a joke about something and someone laughs and we're around a dead body cleaning up. That is not good optics. It's going to look really, really bad for you, in fact. It's going to look very unempathetic to this moment, okay? It's okay to make jokes. It's okay, I wouldn't at the people's expense, but it's okay to cope the way you need to cope. Understand where you are when you do these things is going to make a difference, because end of the day, these people are not going to remember, they're going to remember the death, but they're going to remember how you treated them. They're going to remember how you acted in this scenario. So if you're going to be kind of callous, jaded, and acting inappropriately, they're going to know and they're going to remember, okay? So after resuscitation is stopped, some helpful measures. Take the family to a quiet, private place. You need to have a hard conversation, okay? Use clear language and speak in warm, sensitive, and caring manners, okay? Exhibit calm, reassuring authority. Make sure you use the patient's name. That's a big one. This person's a person, right? Even if to you at a certain point they turn into kind of a cadaver, they are still family. They're still people to the bystanders or to the family around them. Use their name. Use eye contact. An appropriate touch goes a long way. I've had cardiac arrest calls where I had to, the husband expired in the field and I had to go and talk to the wife. They've been married for 40 years. That's something I don't understand, right? I'm not at the same level that they're at in my current relationship, my wife. But use appropriate touch. That woman ended up wanting to hold my hand while I was telling her these things. And that's okay, right? Keep it appropriate. It's okay if people want to have that exchange. Expect emotion. Be supportive, but don't hover. So an example, I ran a call for a hanging. Gentleman hung himself in the middle of the night. The wife is the one that found him. When we got him cut down, I go and I talk to the wife who, unbeknownst to me, his children were also in that room, his teenage children. And I had to have a very hard conversation in front of them with his wife. Now, once I was done having this conversation, I told them, hey, I'm going to be out in the garage. I'm going to leave this door cracked. If you need anything, please don't hesitate to come and get me. Outside of that, I will give you a moment to process this in your own time, okay? And then ask them if a friend or a family member can be called, or even I've had church members call someone from the church to show up, okay? goes a long way, right? It's all about making, because at that point, once our patient is expired, our viewpoint has to shift to the family is our patient, and we need to make sure they are doing okay, right? And I leave it at okay because we're never going to leave them great in these situations, okay? Don't ignore the kids, right? Now, sometimes it's not our news to give. If it's a young child, we're going to let mom or family explain that, okay? But don't ignore them. Keep them in the loop as best you can. Now, one other thing I want to talk about when it comes to this conversation is we need to use definitive language. Dead, deceased. We don't want to say things like they've moved on or they're gone. Okay? We need to be blunt, tactfully blunt, because this is a moment where things can get misconstrued and then people may not understand the situation as we're explaining it, as we're trying to be empathetic, right? But you need to use definitive language. Dead, deceased, not gone or passed on or moved on or whatever you're going to say. So kind of moving away from the sad stuff here for a moment. Education and training. So CPR skills can deteriorate over time, okay? You will, depending on your agency, depending on how they want to run it, either be expected to maintain a 2-year BLS CPR certification. There's also different things like called RQI as an example, where every 3 months you do a CPR recert, okay? But your skills can deteriorate if they go unused. Use them or lose them, okay? So make sure you're staying up to date with whatever practice you need to be doing so that we're, further helping people down the road. And then CPR self-instruction through video and or computer-based modules with hands-on practices out there. Yeah, this is different kinds of courses. It's the same thing. You're still getting the same certification. Just instead of doing a full 8-hour class day, you're doing maybe a 4-hour class day because you did the didactic online work at home, and now you're just doing the hands-on skills. Now, remember, when it comes to the public, we do in agencies train the public in CPR fairly frequently, okay? Remember, we're always patient advocates. We're always doing the best for the patient in the moment we have them to the best of our ability, okay? And you must do your part to facilitate the training of lay people in the critical skills of CPR and AED operation. If you didn't pick up on it during the chains of survival, the links of survival there, the more people who are trained in CPR, the more people who trained in using an AED, the better our outcomes will be because these people are getting the care they need faster, okay? Outside of that, make sure you're being professional and doing your part to educate the people around you.